Hello, and thank you for joining us for this special seminar of the Institute for Health Policy Studies at UC San Francisco. I'm Joanne Spetz. I'm the director of the Institute, and we are very happy to have with us today Mara Decker. Mara Decker will be speaking about adolescent sexual health programs, policy, and politics. She is on the faculty at IHPS and in the Department of Epidemiology and Biostatistics and at the Bixby Center for Global Reproductive Health. She oversees a portfolio of applied research projects and evaluations focusing on sexual and reproductive health, both domestically and globally. She is the principal investigator of a randomized controlled trial that combines in-person health education with digital technology and was designed in collaboration with youth. She has a number of other studies, some of which I think she's going to be telling us about today. So I'm not going to go through her entire bio or all of her many accomplishments and contributions in this area of work right now. I'll let her take it away. I will note that there is a Q&A box or option in these webinar. So if you have questions for her, please type them into the Q&A. And we'll be keeping an eye on those to leave time for questions and answers at the end of her presentation. So Mara, welcome. Thank you for being here with us today virtually.
Thank you so much. And thank you everybody for your patience as we switch from in-person to Zoom. I think after several years of COVID, we're all unfortunately far too expert at all of this. So again, as Joanne mentioned, today I'm going to talk a little bit about adolescent sexual health and hoping that my slides forward. I'm going to talk a little bit about adolescent rights, particularly in California, look a little bit at sexual health education, both the laws and implementation, some barriers to access in terms of both information and services for adolescents, and innovations in the field. Before we go any further, however, we're going to do a quick poll to see what kind of experts you are in terms of adolescent health. So Kat, if you could start the poll now, please. So there's only 5 questions. It shouldn't take too long. And Kat, if you can let me know when we have the majority have voted on all 5.
Unfortunately, I can only get the first question to appear. Oh, wait.
Okay, it looks like question 2 is now coming up. Let's switch over to question 3. We can go to question 4. And finally, question 5. Again, these are all specific to the state of California. Okay, and let's see how you do. Okay, so we're going in reverse order. Question 5, can you get married under age 18 with parental consent? In California, yes, you can. And this depends, again, depending on the state. In Nebraska, you have to be age 19, and in Alaska, you only need to be 14 with parental consent in order to get married. Kat, can we see another one of the answers, please? Can you get a tattoo under age 18 with parental consent? The correct answer in this one is no. In fact, you have to be 18. You're not legally allowed to give somebody under age 18 a tattoo in California. All right. Question 3, what age can you open a bank account without a parent? The majority got this one right. You have to be 18 in order to open a bank account in California. What age can you seek pregnancy-related medical care without parental consent in California? The correct answer is, in fact, any age. There is no age limit or bottom level for that one. And the final question. What age can you seek testing or treatment for a sexually transmitted infection without parental consent? This one is age 12. So thank you for playing. As you can see, the different laws in California and throughout the state really vary. You have different rules around parental consent, the age at marriage, and sexual health education requirements. This map, if you can see the map, I don't know if everybody still has this blocking them, shows the different states that require sex education to include contraception as opposed to only abstinence only. And in fact, only 5 states require comprehensive sexual health education, of which California is one. Furthermore, only 9 states have policies that include affirming sexual orientation instruction for LGBTQ identities and sexual orientation. And 6 states have the opposite. They have policies that include instruction that explicitly discriminates against LGBTQ individuals. For example, rules that state that marriage is between a male and female only, things like that. Not only does sexual health education vary by state, but it also varies by school district, county, and even within the classroom. For example, I received sexual health education by my gym instructor. He certainly was not interested in it, and the entire thing was quite awkward. Other people have the ability to get sexual health education from outside health educators who are really committed to providing inclusive and engaging skill-based education. Fortunately, in California, we have a long history of adolescent sexual health programming. This started back in 1974 with the Information and Education Program, which continues on today. And some of our more recent programming is the federally funded PrEP programming, which is Prevention Education Programming. But you can also see throughout the years that we have a long history of a variety of programming. The Community Challenge Grants, for example, funded over 100 different agencies throughout the state to come up with community-based innovative programming. And then Family Pact is our programming that provides free and confidential services for sexual health services for youth. And the Adolescent Family Life Program, another long-standing program in California, which provides services for pregnant and parenting teens. One of the biggest shifts in California, or continues to build on our long-standing history, is the California Healthy Youth Act, which was implemented in 2016. This requires all schools to provide comprehensive sexual health education, including human development and sexuality education, conversations about pregnancy and contraception options, and sexually transmitted infections. It also incorporates a whole host of other information, including human trafficking, options for pregnancy decisions, and healthy relationships. It is required that all of this is age appropriate, medical accurate, and inclusive, as well as culturally appropriate. Within California, the state funds 22 different agencies in 20 different counties, particularly counties that are seen as high need in terms of health equity. Again, previously they funded over 100, and providing evidence-based sexual health education curricula. And it also requires an inclusion of clinical linkages. This means that not only do you get education, but you're also receive the information about where you can seek services that are youth-friendly and local. Despite all of this, however, and despite all these great efforts in California, youth continue to face consistent barriers to access. We surveyed over 10,000 youth who were receiving programs in California, and this was at baseline, and over 50% of youth still were concerned about receiving test results, the cost of sexual and reproductive health services, and confidentiality. In addition, many youth are concerned about the possibility that providers will be judgmental or disrespectful of them if they do in fact seek services. We also looked at who has greater barriers to access, and this really comes again at an issue of health equity. LGBTQ youth consistently reported greater perceived barriers, particularly around confidentiality and disrespect. Younger teens, understandably, were more concerned than older youth who oftentimes had more autonomy and potentially had already gone and sought services, and also Asian and Pacific Islanders compared to our Latino population. The majority of the youth that we are serving through this programming, about 70% are in fact Latino. And while we didn't look in this particular research, in other studies that we've conducted, rural youth in particular face not only greater lack of knowledge, but also lower usage of sexual and reproductive health services. The good news is, however, that access to information can create a change. That we saw that after receiving sexual health education programming, that youth decreased their concern about the cost of services and their concern about the judgmental staff. However, worry about test results and confidentiality remained among more than half of the students. In addition, we looked at facilitators and intention to use at baseline. And while most of the youth, even at baseline, felt that it was easy to access the clinic, they knew what to expect, and they would feel comfortable talking with a staff member, you still saw over time significant increases in all of these. And that's great to see. Many times we're not sure what youth learn, but this shows that the intention to use in particular, if that they needed services, would go up as well. Some of the lessons learned from our longstanding work with the state and their sexual health education programming is that sexual health education is necessary, but it isn't sufficient. Youth still need access to quality services, particularly youth-friendly services, services that are confidential and affordable. And that privacy and confidentiality remain a big concern. We find this in particular with youth who are in rural areas, and they oftentimes note that somebody that their aunt or a neighbor potentially works at the clinic, and they're really worried about what people will say if they see them even entering the clinic. So after all of this, we thought, well, how can this be improved? We recognized that many youth were still receiving substandard or no sexual health education, particularly some of the most vulnerable youth who frequently move, such as those in foster care, who are unstably housed, and that many evidence-based curricula were developed back in the 1990s with really a focus on HIV education and haven't been updated to be more culturally responsive or inclusive. So we decided to work with our partners in Fresno's Economic Opportunities Commission, and our partners at Youth Tech Health to design a new intervention that was co-designed with youth and grounded in positive youth development and the trauma-informed lens, really emphasizing adolescent rights and providing them with the information and resources that they needed so they could take with them and use whenever they wanted to, not just during the classroom. One of the commitments we had in this program is authentic community partnerships. Again, working with our partners right at the local level as well as the youth to design these programs. And the picture on the right is actually our colleagues at Fresno, EOC, and Youth Tech Health that we presented last week some of our results in Thailand at the International Conference on Family Planning. So continuing an ongoing partnership. And just a quick aside, what does this mean? What does an authentic partnership mean? It means we're really switching from that idea of just occasionally zooming in as researchers into a community, extracting data and then writing our paper, and really getting to that shared collaborative process where decision-making is shared, where trust is built, and this requires an extensive amount of time and commitment on everybody's part. The other component of this, of authentic community engagement, was our process using youth-centered design to develop the curriculum and what ultimately ended up being an app and all this digital integration. So we worked with youth representing different populations, so pregnant and parenting teens, LGBTQ teens, youth in foster care, to really get what they were interested in and what they wanted to build. We started out with the idea of inspiration, talking with them, what do they want, what do they need, and working with them, coming through different activities, different ideas, different possibilities, and doing rapid prototypes with them to ultimately develop and implement what we call In the Know. So In the Know was 3 in-person modules, about 2.5 hours long for each, encompassing sexual and reproductive health, healthy relationships, and education and career success. The app was accessible through both tablets and mobile phones. So if you've had problems with their phones, we always had a tablet available for them as well. This was part of a cluster randomized control trial we implemented in about 55 different sites throughout Fresno. So in foster cares, after school clubs, alternative schools, really trying to prioritize the most vulnerable youth who weren't receiving the services in mainstream schools. So the good news is the majority of youth really enjoyed the program and had positive perceptions of it. They felt that it was clear, they felt respected, and that they were interested in what was happening. And even better is we actually saw changes in behavior. Well, we didn't see much of a change in unprotected sex, primarily because the majority of youth were not sexually active. We did see a significant increase in those who used clinical services at 3 months, and their overall knowledge of information also went up significantly. Unfortunately, due to COVID, we weren't able to follow them for 9 months, but we're happy to see these results. Again, other comments that the youth made, just that they really thought it was important. They hoped that this could be expanded throughout, and that the energy was welcoming and engaging. So a couple of lessons learned from this program. Number one is that technology and digital technologies are a tool. It's not the solution. We assumed that you always hear that digital technology is ubiquitous among youth, but we found in fact that not all youth actually had access to technology. Many youth shared phones or had phones that didn't have much of a battery power, couldn't download an app easily. And ultimately, they ended up not using the app much outside of the classroom. They did not sign up for text message reminders. They did not use the resource locator. What they really ended up loving were the health educators and the technology that was being used in the classroom to be more interactive. Creating a truly engaging curriculum takes time. We tried to do this whole program in just 6.5 hours. It turns out that in order to have more time to practice, to ask questions and have answers, all of that, needed more time. So the Ultimate program is now expanded to about 8 hours. And rather than have it based on an app, the next iteration of this is going to be on a mobile enhanced website so that youth can use this at any place that they need. And another important lesson learned is while we did all this co-development and usability testing with the youth, we never talked with health educators. We didn't check with them to see their comfort level with the technology and what worked well and what could be improved. So we ended up having to rapidly create additional training and support for the health educators, as well as easy ways for them to provide feedback when something wasn't working. So recommendations for those of you who might be considering something like this. First, the importance of centering and engaging youth at every step of the process. Secondly, making sure that you're building strong and trusting partnerships, not only with your community-based organizations, but also with the youth that you're serving. Planning for ongoing improvements and updates. Again, oftentimes people develop a new app or a website and they don't think about the time that it requires to make sure that it's continually updated, that those links work, that if Android or an Apple phone updates, that you need to update your app as well. And thinking about other outcomes. This was developed for a federally funded teen pregnancy prevention program, so they were really interested in those sexual health outcomes, but we're interested in other types of positive youth development as well. So after all of that, we thought, well, what else could we do? After several years focusing on technology, which included also a transition to an online implementation during COVID, we decided to do something different. We decided to look at the needs of youth in rural Fresno County, and we decided this time to continue to work with our colleagues at Fresno Economic Opportunities Commission and also with the Fresno County Superintendent of Schools. And with this project called the Rural Education Development for Youth, or the READY project, and youth designed this icon for us, we came up with, we started out just by working with them, conducting focus groups with youth in these rural communities, as well as youth serving professionals, asking them, what do they need and what could be improved. And they made multiple comments, one of which was that while many youth remembered receiving some kind of sex education in middle school or high school, they didn't really remember anything. They also wanted broader education about areas of sexual health, particularly around sexual orientation and gender identity. And both youth and youth-serving professionals raised concerns about adolescents' mental health, especially during COVID, and discussed the limited knowledge and services available. They also recognized that community stigma affects youth access to sexual and mental health information, social support, and health services, and that youth in underserved communities and under-resourced communities face additional obstacles in navigating the transition to adulthood. Youth-serving professionals in particular stress the importance of learning things like time management, balancing school and work, career planning, and financial decision-making. And just as a quick aside, this population is distinct from the other group that we were working with previously. This is over 95% identify as Hispanic or Latino. Also ended up being a little bit older. And because they were older, almost half of them had ever had sex, and about a third of them were currently in a relationship. So based on that feedback and with our partners in rural Fresno County, we really addressed this from a systems thinking approach. Again, centering youth, but looking beyond just comprehensive sexual health education to also look at strengthening the local healthcare system, the support of families and caregivers, and also continuing to recognize the different laws and policies that are impacting youth. So similar to the other one, we worked with a youth advisory council to identify and develop what we called a booster curriculum. So not only did we provide the comprehensive sexual health education as required by the schools In ninth grade, we developed a new curriculum for youth in 11th and 12th grade. So those who are transitioning out of high school and either going on to get a job or going on to community college or college. And working with the youth with this, we created 5 different modules. One, focusing more on that preparation for adulthood that I previously mentioned. 2, sexual identity and inclusivity. 3, healthy relationships and how to identify healthy or unhealthy relationships. 4, sexual and reproductive health. And 5, really looking into and going deeper into mental health, well-being, and how to advocate for yourself in terms of the services that you may need. This program is still in its infancy. We've been working on this for about 2 years now, and in the preliminary data, though, shows great increases in knowledge, both in terms of sexual health knowledge, but also around mental health and healthy relationships. And we also saw a big increase in their awareness of sexual and mental health services in the community. So they knew where to get mental health counseling, sexual health services, and knew some of their rights, such as that teens do not need to pay for sexual and reproductive health services at a family packed clinic, and that they don't need parent or guardian permission to receive sexual and reproductive health services or to leave school in order to seek those sensitive services, including mental health or sexual and reproductive health. Some of the lessons learned from this program is, first and foremost, that Zoom does not replace in-person partnerships. We developed this program the first year during COVID, so we were unable to go to Fresno County for the first year. At this point, we're now back in person, and it makes such a difference. It makes such a difference to actually see what's happening in the room when there's 75 kids in a cafeteria getting sex ed, when some of them don't speak English, how the health educators are adapting to all of that. Really, that reality setting is so incredibly important. Secondly, the importance of buy-in. So this is not only with our partners, but with the school district, with the principals and others on the school council. Also, although Fresno County is doing a great job trying to provide additional mental health support through the schools, they have a program called All for Youth. Those needs are still unmet. Many youth still are concerned about the stigma around seeking services, say that their parents aren't necessarily taking their concerns seriously, and they're just still not quite sure where to go. In addition, not only do the kids not know that, but parents and teachers also really need additional information about mental health and resources in the area and warning signs. Similarly, the parents and teachers really are craving additional information about how they can be better advocates and support for youth in their communities. So recommendations related to this one is the importance of incorporating mental health and a trauma-informed lens in the work that we're doing with youth. While mental health was already starting to look bad or starting to get worse prior to COVID, COVID really escalated the situation and become a crisis in many of these communities. Also, the importance of engaging broader communities. So this picture is from the Latino Heritage Night in October, where all sorts of different groups came together to the small town of Mendota and offered services and made sure that people knew they were available, and also helped to network among their own group. And the importance of expanding access to sexual and reproductive health services. These communities, currently, none of them have a family pack provider, which means that youth either need to get transportation to a place in another city nearby, which could be 45 minutes to an hour away. But our colleagues at Fresno ERC are providing vans to youth. They also are trying to work and develop a pop-up clinic that they can go to, say, 1 or 2 times a week. COVID has also taught us of the possibilities and the challenges around telehealth for youth. While telehealth can be a great boon there's still inequities there. Youth in rural areas don't have broadband access oftentimes. They may not have a private place where they can actually ask questions of a provider. So I think we need to think about which kinds of contraceptive services can be available through a pharmacy, for example, that doesn't require a prescription in advance, and what can be provided over the counter. So what are we going to do next? We want to do a lot of things. First, we want to really rigorously evaluate the booster curriculum and see if it can be appropriate in other settings outside of these majority Hispanic rural communities. Expand to new sites, particularly looking at sites that have refugees and other newcomer youth. We're in the middle right now of interviewing parents with their teens separately, asking them about their communication around these topics, what they are worried about, how they can support each other. And that has really been a joy, listening to the concern that parents have, their dedication to providing whatever support they can to their youth, and also hearing from these 14-year-old boys talking about how great their moms are. So we're continuing with that. And finally, looking at, we've conducted a mystery client assessment of the clinics in the area and the broader catchment area, given that there are so few clinics in these rural areas. We want to do the same with pharmacies and see what kind of services they actually provide for youth. So here's a couple of resources if you're interested in more information, either in our program or the Youth Rights, the National Center of Youth Law and Teen Rights. And finally, I want to stress my incredible appreciation for my team at UCSF, who are up on the right. They are what makes all of this possible, as well as my partners in Fresno. And finally, my teens, who always make sure that I'm not too far off the track when I'm talking about adolescents on the left. So that is my presentation. I think I will turn it over to Joanne. Do you want to help with the Q&A?
Yes, indeed. So anybody who's there in the audience, there is a Q&A box, so please enter your questions here. So the first question that we have is from Janet Kaufman, and she asked, do you have any insights as to why Asian and Pacific Islander youth are more likely to perceive barriers than Latinx youth?
That is a great question. One of our theories, and it's just one of them, is potentially there's still some cultural stigma around this. Interestingly enough, we actually saw fewer perceived barriers among Black youth, and we saw fewer perceived barriers among youth who were in juvenile detention centers. So some of those expectations actually, I think, go against what one would expect. Big barriers for youth in foster care, however. But yeah, I think for Asian American youth, it really is still a little bit of a culture for some people. It's obviously a huge generalization when we're talking about Asians and Pacific Islanders, because that's a whole lot of different groups. And again, just I think the other big piece is that about 70% of our population was Hispanic Latino, so much smaller groups being represented elsewhere.
Great. Okay, we have another question from Sarah Garrett, who thinks this is amazing work, she says. And she wonders if you could share about how you and your team approached building and sustaining your strong community relationships in Fresno. And that actually is very similar to a question that I would have asked. So thanks for asking it ahead of me, Sarah.
Yeah, thanks, Sarah, for asking that. I think it's just so critical. I think there's a lot of lessons learned, right? Number one is the humility to recognize that our colleagues in Fresno are the experts of Fresno, that we might bring some statistical expertise, but ultimately they know their community better than we do. And even more so, the youth know what they need much better than somebody approaching my age. So first is, I think, transparency, really stating, okay, this is the budget, this is what's going on. They co-wrote the grant application with us. So everybody was kind of clear as to roles and responsibilities from the beginning. Our youth tech health colleagues were the ones who designed the app. Fresno EOC was the ones who implemented it, and then we were the researchers and evaluators. We had constant communication. We met weekly on calls, but we also regularly went down to have meetings and conducting focus groups with youth, all those types of check-ins, so that we were talking. So we had a weekly meeting on that, but also we had health educators. We would have a check-in with them every single week and after any implementation. So, and I'll also call out, I don't know if Salish is on the call right now, but we, one of the health educators from Fresno EOC is now on our UCSF team, and he has been a fantastic bridge between the different groups.
Great. We have a question from Dan Doan, and he asks, well, he says he's curious to hear more of your impressions of youth relationships regarding schools and clinics. For example, do youth tend to like and trust both, like and trust one but not the other? And what are your impressions of the factors or interactions or experiences that can move the needle in terms of trust and engagement or creating distrust with these institutions?
Great question, Dan. I will speak when I'm thinking about the one about schools, particularly for the rural health. Youth and family members in general kept talking about schools as a real hub for their community. Schools are about the only thing happening in many of these rural communities. So there is great trust and great reliance on the schools. We are fortunate in that the schools that we're working with, they supported us. They supported us going in, and we're providing, and I guess I didn't talk about this, but we were also providing education nights for the parents and staff training exercises for the teachers as well. So we were fortunate in that we could help to uplift all of this and really work with them to see what they needed. I think that's one. Clinics is a challenge. Students would love to have more school-based health centers. However, in the state of California, I think we have about 280 school-based health centers. There's still a lot of opportunities there to continue to build and grow that. Biggest thing for youth to build trust is make sure that you have protocols, policies in place so that their confidentiality and privacy is protected. Making sure that those insurance notifications don't go out to parents. Making sure that they just have a private wait room so they don't have to be sitting in public. And then that concern about respectful care. Why this continues to be a finding is just so discouraging. Of course, youth and people of all ages want somebody who isn't judgmental and treats them with respect. But that starts from the people at the front desk. If you come in and you're like, why are you here? You didn't make an appointment. You're too young to have sex. That's gonna turn away not only those youth, but all of their peers, because they're gonna hear about it. So making sure that people throughout the clinic know that and know how to be respectful. At the schools, making sure that they know the laws, that students are allowed to leave for confidential health services. Many schools don't know that, and they will automatically call the parents to say that, your son or daughter has been marked absent during this time. And Dan, I may have missed part of your other question.
I'm checking to see. I think you have largely hit his key domains, but he can type in another question if he has a follow-up. Claire asked a question that I think is related. So she's added a few questions, but I'm going to go in the order as a follow-on logically from what you just answered. Is that, the polling at the beginning of the talk revealed information about the rights that young people have. And Claire wonders how aware the youth and their families are regarding their rights in these areas. Do they seem pretty knowledgeable of these things, or is that an area of education that you've had to focus on or include and be aware of in your work?
Thanks, Claire, so much for the question and for joining. I want to just stress that Claire really is the builder of so much of this work and is the reason that I started working with the state of California on these sexual health education programs. And now you just took the question away. Now I can't remember.
Yeah, the question.
The question about, I remember, the policy. Youth are not aware of this. I don't think parents are aware of this. I don't, even to do this, I had to look up, like, I don't know what the rules are around bank accounts. And I have two 15-year-olds. So it's extraordinarily challenging. And I think there's a reason we're not aware of it. Those questions show you what a mismatch of policies there are, that in some aspects, minors have incredible rights, and in other ones, they're still very protected. I'm not even talking about when you can rent a car, for example. So it's confusing and challenging, but I think one of the pieces that we really are trying to do is educate youth on their rights, the fact that they can have access to confidential services for free from family PAC providers, but the fact that they can seek these services, that mental health services are one of those components. And again, I think a lot of not just adolescents, but young adults and even older adults are not aware of these rights and their privacies and protections either. So a lot of work that can be done there.
So in thinking about future work, Claire asked a question about the challenges of pursuing funding in this arena in terms of federal and state funding. What have been your experiences in that, and any guidance you might give to others interested in this type of work?
Well, I'm going to, rather than do a challenge, I'm actually going to talk about an opportunity that I think is really exciting. I think federally, the federal government is moving away from these very traditional teen pregnancy prevention, biomedical individual models, and looking much more broadly at issues of health equity and other innovative approaches that we can do to support youth. So that, and looking at sexual health more broadly. So that I think is really exciting. Some of the challenges, however, I think challenges in whether it's sexual and reproductive health or anything, anytime you try to do community engaged work is always a challenge, because you're saying that you're going to develop something that is going to take years to develop in an authentic way, and you have to set it ahead of time for the grant. So it's this kind of contradictory thing where you have to say, for the grant that you develop in a couple quick months, these are our outcomes and this is what we're doing, and then you want to still spend a year to really develop it with youth or with your community partners. In terms of state funding, the state of California really has reduced their funding for sexual health education, just period. They have moved away from that since the recession. So about 10 years ago, a lot of their funding streams, their state-funded money went away. And now really what's remaining is just some small federal funding. So very different kind of environment there, and much more limited. That said, the good thing is that the state of California now requires comprehensive sexual health education. So there's lots of opportunities for research and other activities, but it's just much more, I think, piecemeal than it used to be.
Great. So I'm gonna pop in with a question. I'm curious about what you are thinking about as kind of a next area of inquiry. What remaining questions have you been coming out of this body of research in that you would like to pursue answers to? Or are there different communities that this type of a strategy may produce some novel information or guidance for a different population of youth or a different kind of community environment?
Thanks, Joanne. I think the issue around booster sex ed, I think is important kind of across the board. When you think about potentially what you received or what your children received, it's generally a couple days in maybe 6th grade and a couple more days in 9th grade. And the development, both social development, the plasticity of the adolescent brain between age 14 and 18 is tremendous. So you think about even where you were when you were 18, you're much more likely to be in a relationship. You're thinking about those next steps that as a 14-year-old, you're not. A 14-year-old, when you're saying, here are all these different kinds of contraceptive methods, and they're not even dating anybody, it's important that they get that information then, but that supplemental information, that repetition and going deeper, I think is really critical. And most places don't offer this at all. So thinking about how we can expand these opportunities for supplemental sexual health education, including potentially at community colleges, because a lot of youth that are coming into community colleges have limited information, maybe didn't come from California originally, so they didn't even get the basics, and have really limited knowledge, even about basic anatomy. So that's one piece I would love to expand to. Looking further about the needs for refugee and other newcomer youth, so youth who potentially didn't receive any information earlier on, didn't receive puberty talk, anything like that. I think there's a broad possibility of going to there. Our hope would be also kind of because we're at the Institute of Health Policy Studies, looking at this from a bigger policy level. So having districts really commit to, at the policy level, this type of programming, because the state of California is local decision making. It'll be more difficult to have a state mandate, but at least if we can get some school districts to build this and then have it expand beyond there. And I think also parents are more likely to be supportive of an 18-year-old receiving this information than a 14-year-old. We haven't really received any pushback from the parents or guardians, and if anything, again, the parents just keep asking for more.
Great. I see another question has come in from Janet. Let's see. So let's see. I'll just read her whole thing because I can't process it quickly enough. So Janet wrote, excellent presentation and discussion, Mara. Very important insights about the strengths and the limitations of cell phone-based interventions. One thought, given the many youth identified mental health as a need, the state is investing a large amount of funding in the Children and Youth Behavioral Health Initiative. And Janet wonders if that could be a source of funding for education and support for building healthy relationships.
Janet, that is a great idea, and a terrific point and suggestion. We've seen this also just again at the local level in Fresno. One of the things that they did with a lot of their COVID funding was expand this mental health piece called All for Youth. Our biggest concern is it going to continue? We certainly hope so, but I would love to hear your thoughts about that and see if there are potential opportunities. We're actually working with another colleague at UCSF, William Martinez, who has done a lot of work with trauma-informed care in immigrant youth. And that's another area that we're really interested in, and looking particularly at refugee youth who just by definition are fleeing some trauma or some severe challenge, thinking about what we can do to better support them in a culturally appropriate, language appropriate way.
Well, thanks, Mara. I don't see any other questions in the Q&A box right now. And we are just about at 10 till the top of the hour. So it seems like a good time to thank you for your presentation and for educating all of us about this area of work in general and all of the things that we probably don't know, or many of us don't know, about children's privacy and families' kind of obligation to protect children's privacy, as well as this body of research, which is having a huge impact in an area that is near and dear to me since I grew up in Bakersfield, just a couple hours south. So thank you for your time today. And everybody, Mara is very easy to find online. So if you have any questions for her, look up her profile or look her up on our IHPS website, and you'll be able to contact her and ask her questions directly. So thank you for being here, and thank you everybody for joining us.
Thank you so much.